Now that we've got a good idea of the theory and principles that can guide our decisions with the PT/PTA student team, it's time to talk about the nuts and bolts of how to actually implement this idea. In this session, we'll introduce a supervision model that you can replicate or modify for your own setting. The model we're introducing is based on a framework that Lynham and colleagues designed for dietitian clinical education back in 2014. They had a small group of clinical educators implement a 2-to-1 model and then asked for their recommendations on how to best implement that model. The participants in Lyman's study reported that for this model to be effective, clinical educators needed to be trained on how to schedule individual and group feedback and how to facilitate peer feedback. Several years later, Alpine and colleagues modified the framework for use in physical therapy clinical education. In the Alpine study, the authors reported that a key component of the model was the way that they implemented peer observation, scripting, and feedback. According to their report, this process allowed for valuable self-reflection and peer review. Before we look at a graphical representation of this model, here's a brief overview of its organization. It incorporates 4 different scenarios that include various learning roles for each student. In the first scenario, both students observe the CI, and this is the CI's chance to model expected behaviors. The other scenarios include combinations of various student roles, such as leading, observing, peer assessing, co-treating, and independently treating. Students will typically progress through the scenarios in order, 1 through 4, as they become more independent. Each scenario emphasizes unique aspects of collaborative learning, allowing CIs to emphasize different learning opportunities at the right times. This includes both independent and collaborative practice, as well as group and one-on-one instruction. So here is what the model looks like at a glance. I know it's a little busy, so let's walk through it step by step. In the first column, we have a list of the different tasks associated with patient care, along with a few peer learning activities. Peer scripting refers to the observer's role in documenting, as much as possible, the words and actions used by the lead student, and then presenting that script in the feedback session. Since scenario 1 is purely observational, it's not listed here on the model. In each of the other scenarios, you'll see 2 columns, one for students and one for the CI. The A and B in the first column indicates the role of each student, with A being the lead and B being the observer. The second column simply shows whether or not the CI is present for that activity. So in scenario 2, both students are present for the patient interaction, but one is the lead and the other is the observer. Students would take turns in the lead role for consecutive patients, so in other words, with every other patient, the students switch roles. This scenario is heavily focused on peer learning, with breaks in the patient interaction to accommodate collaborative learning opportunities, such as presenting findings to one another, peer evaluation, and step-by-step feedback. Looking at the first column in scenario 2, you'll see that both students are involved in data collection, but student A, the lead student, takes over the subjective and objective assessment, treatment and documentation, and presentation of findings to the CI. Student B, the observer, is responsible for peer observation and scripting, helping with treatment planning, providing peer feedback and assessment, and engaging in overall feedback. The CI can decide when they need to be present based on the lead student's level of independence. Scenario 3 looks a little different because in this scenario, both students are independently seeing their own patients without their peer partner present. So in this case, the CI will be present for one of the students, but not present for the other. This scenario could also be used when one student is engaging in an alternative learning activity, such as shadowing a doctor, observing a surgery, or sitting in on a speech evaluation. You can also see that in this scenario, the peer learning activities are not performed. In scenario 4, the students are more advanced and able to flow through the patient interaction without any interruption or instruction. Presentation of findings and peer feedback are postponed until after the treatment session has been completed. In this scenario, the CI may choose to be present or to observe from a distance and just join the students for the debrief and reflection at the end. As you see, This model gives students excellent opportunities to learn with their peers and to learn independent clinical skills. So that's how Alpine and colleagues implemented the 2-to-1 model with 2 PT students. However, we're here to talk about using the model for PT-PTA student teams. Since the PTA student won't be directly involved in things like evaluation and discharge, we'll need to modify Alpine's model just a little bit. For starters, we'll only apply the model to routine patient visits, not new patient evaluations. It'll still be valuable for the PTA student to sit in on some evaluations, but this would only be as an observer with some opportunity for peer scripting and peer assessment. The only other change to Alpine's model is that treatment planning becomes plan of care review and adjustment. In this activity, students collaboratively review the already established plan of care and make appropriate adjustments in response to the patient's presentation. Keep in mind, this model is a framework, which means that you can use it as a basic structure on which to build your own approach. As you apply this in your practice, there are a few key components to the framework that are going to be crucial for your success. First, it provides an organized, structured way to schedule important learning activities in a PT-PTA student team. This will help ensure that you don't miss valuable collaborative learning opportunities. Second, it includes opportunities for students to intentionally observe one another and provide specific feedback on performance. This not only helps the student receiving the feedback, but it also helps the observer who benefits from seeing their peers' successes and struggles. Third, the framework has time built into it for one-on-one time with the clinical instructor. Research has shown that this time is important for individualized feedback and for enhancing student satisfaction. Fourth, students are given opportunities for independent as well as collaborative patient interaction. Both are extremely valuable in helping students acquire their clinical skills. And finally, the framework provides what Lynham calls protected time for self-reflection and peer feedback. This reflection and feedback will ultimately lead to quicker clinical skill acquisition and higher quality student-to-patient interaction. Knowing how to actually structure the day-to-day schedule can clear the way for you to explore different ways of facilitating peer learning with your students. We'll be introducing some of these exciting methods in our last 2 modules of this course. Thanks for listening. We've included a copy of the model as a PDF in your Canvas module so that you can save it, print it, and refer to it as often as needed. And here are the references that we used for this presentation.